So in our discussion about the proximal humerus fractures, we will start with an introduction. So proximal humerus fractures are common and they are accounting for 5% of all adult fractures. And proximal humerus fractures mostly occur in elderly patients, especially patients who are osteoporotic, for example, postmenopausal women, and they are one of the most common fragility fractures. And fragility fractures are fractures that occur in the osteoporotic bones, and the most common ones are the proximal humerus fractures and the distal radius fractures and the vertebral compression fractures. And proximal humerus fractures occur mostly after low energy falls. And there is options for operative and non-operative treatment for these fractures, and deciding between them can be very difficult. So to really understand the proximal humerus fractures, first we have to understand the anatomy of the proximal humerus. And the proximal humerus consists of 4 major parts. They include the anatomical head, the greater tuberosity, the lesser tuberosity, and the shaft. So as you can see in this picture, we have the anatomical head here, we have the lesser tuberosity here, we have the greater tuberosity here, and we have the shaft here. So starting with the anatomical head articulates with the glenoid cavity of the scapula bone. So this is the anatomical head, and you can see that it is articulating with the scapula bone to form the shoulder joint here. And the humeral head is directed predominantly medially and oriented superiorly by 130 degrees and anteriorly by 30 degrees. So the humeral head is directed medially, so it is directed to the medial side, as you can see, and it is oriented superiorly by 130 degrees. So if we draw a straight vertical line here, so we can see that the humeral head is directed medially to this side and is oriented superiorly by 130 degrees. So this angle here is 130 degrees. So if we had a 3D picture of the humeral head, we can see that the head of the humerus is oriented anteriorly by 30 degrees. So it is oriented to the anterior side by 30 degrees. And those numbers are beneficial in the reconstruction of the humerus in complex fractures. Now we mentioned that in the anatomy of the proximal humerus, we have the anatomical head, the lesser tuberosity, the greater tuberosity, and the shaft. Now after the anatomical head here comes the anatomical neck, which is in green. So this is here the anatomical neck, and the anatomical neck of the humerus is formed by a groove around the anatomical head, and it separates the head from the tuberosities. And the anatomical neck is the line of attachment of the glenohumeral joint capsule. So it is the attachment of the shoulder joint capsule. And after that comes the tuberosities. So we have the greater tuberosity, which is at the lateral aspect of the humeral head and is the site of insertion of 3 of the rotator cuff muscles: the supraspinatus, the infraspinatus, and the teres minor. And this is here the greater tuberosity. And medial to the greater tuberosity, we have the lesser tuberosity, which is placed more anteriorly and is the site of insertion for the subscapularis muscle. So this is the lesser tuberosity and is the site of insertion for the 4th rotator cuff muscle, which is the subscapularis. Now the greater and lesser tuberosities are separated by the intertubercular sulcus, which is also called the bicipital groove. So here we have the lesser tuberosity, and here is the greater tuberosity, and between them is the intertubercular sulcus, which is also called the bicipital groove because the tendon of the long head of the biceps muscle pass through this groove. That is why it is called the bicipital groove. Now, in proximal humerus fractures, when a tuberosity fractures and gets displaced, the attached muscles lose their function, and this is equivalent to a rotator cuff tear. Now, the anatomical head of the humerus and tuberosities make up the surgical head. So we have the anatomical head here, we have the tuberosities here. If we collect them all together, we get the surgical head of the humerus. And the surgical neck of the humerus lies at the junction of the surgical head and the shaft. And the surgical neck is in the blue color, as you can see here in this picture. So now we have an anatomical neck and a surgical neck. And we have an anatomical head and a surgical head. And the surgical neck is a common site of fractures. Now here we have pictures for the areas of muscle attachment to the humerus. So the right picture is for the anterior view and the left picture is for the posterior view of the humerus. So we have the subscapularis attaching to the lesser tuberosity on the anterior view, and we have the supraspinatus, the teres minor, and the infraspinatus all attaching to the greater tuberosity, the supraspinatus attaching to the anterior side of the greater tuberosity, and the teres minor and infraspinatus attaching to the posterior side of the greater tuberosity. And then back to the anterior view, so we have the teres major and the pectoralis major attaching to the edges of the bicipital groove here, and we have the latissimus dorsi attaching to the floor of the bicipital groove. And below that, we have the deltoid muscle attaching to the deltoid tuberosity, and we have the coracobrachialis attaching beside the deltoid, and then below that, we have the brachialis muscle attaching to all of this area below them. And on the posterior side, we have the triceps attaching here and here, and we have the brachialis attaching to the lateral side, and we have the brachioradialis attaching also to the lateral side but inferior to the brachialis. Now there is nerves and vessels passing near the proximal humerus. So we have the brachial plexus and the axillary artery both run together medial to the coracoid process of the scapula and medial to the conjoint tendon, which is the coracobrachialis and the short head of the biceps, and into the arm. And both of these structures could be injured in proximal humerus fractures. And you can see them here in this picture. So here we have the axillary artery and beside it the brachial plexus. Now let's talk about the mechanism of injury. So proximal humerus fractures usually caused by a fall on the outstretched arm or a fall on the shoulder in elderly patients, or they are associated with high energy trauma in younger patients. Now, the same mechanism might cause shoulder dislocation, and sometimes a fracture and a shoulder dislocation will present together. Moving on to talk about the classification of proximal humerus fractures, and the most accepted classification for these injuries is the Neer Classification. So in Neer Classification, the proximal humerus fractures are classified according to the number of parts involved. And the proximal humeral parts include the anatomical head, the greater tuberosity, the lesser tuberosity, and the shaft. So the anatomical head, as you can see in this picture, the lesser tuberosity, the greater tuberosity, and the shaft. So proximal humerus fractures are classified according to these 4 parts. And for a part to be counted in the classification, it has to be displaced. And a displaced part is defined as a part displaced by more than 1 centimeter of translation or more than 45 degrees of angulation. If displaced less than that, then the part is not counted. And according to that, the proximal humerus fractures are classified into one-part fractures, which are the minimally displaced fractures. That is when there is no displacement of any part. That is when we call them a one-part fracture. Then we have a two-part fractures. That is when one of the parts is displaced by more than 1 centimeter of translation or more than 45 degrees of angulation. And then we have three-part fractures. That is when two parts are displaced. And four-part fractures, that's when their three parts are displaced. Now here we have examples for minimally displaced fractures, which are called the one-part fractures. So here we have a one-part anatomical neck fracture that you can see right here. And here we have a one-part surgical neck fracture. And here it is one-part greater tuberosity fracture. And finally, we have a one-part lesser tuberosity fracture. Now there could be more than one fracture line. There could be multiple fracture lines like here, here, and also here. And they all are not displaced. And they also called minimally displaced, or they are called a one-part fracture. Now regarding the two-part fractures, so these are classified into a two-part surgical neck fractures, which are the most common proximal humeral fracture type. And the two-part surgical neck fractures is here in this example. And in the two-part fractures, we also have the two-part greater tuberosity fractures that you can see here, and a two-part lesser tuberosity fracture that you can see here, and a two-part anatomical neck fracture that you can see here. Now regarding the three-part fractures, so in the three-part fractures we have the three-part lesser tuberosity and a surgical neck fracture, and we have a three-part surgical neck and a greater tuberosity fracture. And we have the four-part fractures. As you can see in this example, we have greater tuberosity, lesser tuberosity, anatomical neck, and a surgical neck fractures, and they are all displaced. Now, this classification is not perfect, and there are some scenarios that are not included in this classification. So, for example, we have a fracture dislocation. So, a fracture dislocation occurs when there is a fracture at the proximal humerus with a dislocation of the humeral head out of the glenoid. And we also have the valgus impacted fracture, which has intact periosteal hinge medially. So in the valgus impacted fracture, we have the medial hinge is intact of the humerus, as you can see in this picture. And despite the displacement of the anatomical head, it can be reduced by surgical leverage on the hinge. Now let's talk about the clinical features. So the patient present holding the affected arm close to the chest, supported by the other hand, and they complain of moderate to severe pain. And on orthopedic examination, so on the looking part, so when you look to the upper arm, there might be a little swelling, but no bruising initially. But after a few hours, extensive and deep bruising may develop on the arm and down to the elbow. And skin puckering anterolaterally suggests that the deltoid muscle became interposed within the fracture fragments, and this will slow the healing process. And if you ask the patient to move their shoulder, they can't move their shoulder. And of course, you have to examine for neurovascular injuries, and you also look for other injuries. Now let's talk about the imaging in these injuries. So the AP lateral, and axillary views of the X-rays are ordered, and in elderly patients, the fracture lines are not seen well, and it's mostly one fracture line extending through the surgical neck. But in younger patients, the fracture lines are seen better and the fragments are more clearly separated. Now, the axillary and lateral shoulder views should be obtained to exclude dislocation and to look for the greater tuberosity displacement. And as you can see here in the AP shoulder X-ray, we can see that we have a surgical neck fracture here. It is a two-part surgical neck fracture. Now, CT scanning shows fracture lines and displacement much better, and it is essential for planning surgical reconstruction of complex fractures. And with repeated X-rays through the healing process, the humeral head is seen to be subluxated downward, and that is due to muscle atony. And it usually recovers once the exercises are begun. Now let's talk about the treatment. So, proximal humerus fractures can be treated by many options. So they can be treated by either a sling or a collar and cuff immobilization, and this is a type of non-operative treatment. Or they can be treated by percutaneous fixation, or open reduction and internal fixation, or arthroplasty. And all three of those are operative treatment methods. And close reduction is not required for these injuries because these fractures tend to realign over time as a result of the traction exerted by the weight of the arm, and if a sling or a collar and cuff is used. And there is no form of cast that is beneficial for these fractures, and patients who are treated non-operatively will get a satisfactory functional recovery most of the times, while patients treated operatively will not regain a satisfactory function of the shoulder. For example, they would have stiffness, weakness, and pain. And that is why deciding between operative and non-operative treatment methods can be very difficult. Now let's start by explaining the treatment of minimally displaced fractures. Those are also called the one-part fractures according to Neer Classification. So they are treated non-operatively with a sling immobilization for 4 to 6 weeks. And the patient is advised to remove their cuff or a sling several times a day and begin pendural exercises immediately when pain allows, and progression to shoulder exercises as soon as possible to prevent stiffness from occurring. And elbow and hand exercises should be done from the start to prevent stiffness to these joints. Now, regarding the treatment of the two-part fractures, so those are classified into the two-part anatomical neck fractures, the two-part surgical neck fractures, the two-part greater tuberosity fractures, and the two-part lesser tuberosity fractures. So starting with the surgical neck fractures treatment, so those are treated non-operatively with a sling immobilization for 4 to 6 weeks. And if the fracture is unstable, then operative method is used, for example, percutaneous pins or plate fixation, which is an open reduction, internal fixation type of method, or an intramedullary nail, which is also an open reduction, internal fixation type of method. So same with the first one. So pendular exercises should be started as soon as possible, and progression to active shoulder exercises should be done, and hand and elbow exercises should be done from the start. Now, regarding the treatment of the two-part greater tuberosity fractures, so those that you can see in this picture here, so if these fractures are not displaced or displaced by less than 0.5 centimeter, then treated non-operatively with a sling immobilization for 4 to 6 weeks. But if they are displaced more than 0.5 centimeter, then treated operatively with isolated screw fixation or non-absorbable suture or tension band wiring. And sometimes the two-part greater tuberosity fractures are associated with anterior shoulder dislocation, and they reduce when the shoulder relocates in most of the cases. Now, regarding the two-part lesser tuberosity fractures that you can see in this picture here, so those might be associated with posterior shoulder dislocation, and if they are minimally displaced, then treated non-operatively with a sling immobilization for 4 to 6 weeks. But if large fragment or displaced, then treated with open reduction internal fixation. Now, regarding the two-part anatomical neck fractures that you can see here in this picture, so those are rare and they are treated with open reduction internal fixation if the patient is young, but if the patient is old, then prosthetic replacement, which is hemiarthroplasty, is preferable due to high risk of avascular necrosis associated with these fractures. Now, regarding the treatment of the three-part fractures, so these usually involve displacement of the surgical neck and greater tuberosity, which is the example that you can see here, but sometimes they involve displacement of the surgical neck and lesser tuberosity, and they are difficult to reduce by closed methods, so they are treated operatively with percutaneous pinning or open reduction and internal fixation using various methods. But if the patient is elderly, then arthroplasty is needed. Moving on to the treatment of the four-part fractures. So in this type, the surgical neck and both the tuberosities are displaced, like you can see here in this picture. So if the patient is young, then open reduction internal fixation if the proximal humerus is reconstructable. But if it is not reconstructable, then hemiarthroplasty is done. But if the patient is elderly, then hemiarthroplasty in all cases. Now, the four-part fractures are severe injuries with high risk of complications such as vascular injuries, brachial plexus damage, chest wall injuries, and late avascular necrosis of the humeral head. Moving on to talk about the complications of the proximal humerus fractures. So complications include the neurovascular injuries. So the patient should be assessed for signs of these injuries by palpating the brachial artery, so to make sure that there is no axillary artery injury, and a neuro exam is done to check for the brachial plexus injury. And the axillary nerve especially is at high risk of getting injured. Another complication is infection, and infection is accounted for if the fracture was open or if the fracture is treated operatively. And also another complication is non-union. Non-union occurs especially in two-part surgical neck fractures, and also malunion. Malunion causes little disability, but it leads to loss of rotation, which make it harder for the patient to reach behind neck or up to the back. And with these injuries comes the possibility of rotator cuff tear. Another complication is adhesive capsulitis of the shoulder joint. And this complication leads to stiffness of the shoulder, which is also called the frozen shoulder. And it is a common complication, especially in elderly patients, and it can be minimized by starting exercises early. Another complication is the avascular necrosis. So the avascular necrosis of the humeral head is a segmental necrosis of the devascularized anatomical head of the humerus. And this is seen by the X-rays. And spontaneous revascularization commonly occurs, but sometimes it doesn't, and the head collapses. And in this case, hemiarthroplasty is required. And the avascular necrosis of the humeral head occurs in up to 30% in three-part fractures and up to 50% in 4-part fractures. Now, to really understand the avascular necrosis, we have to understand the vascular supply to the humeral head. So the avascular necrosis occurs when the vascular supply to the humeral head gets disrupted. And the vascular supply to the humeral head arise from the anterior and posterior circumflex humeral arteries. And both of these arteries are branches of the axillary artery. So as you can see in this picture here, we have the axillary artery here, and here we have the posterior and anterior circumflex humeral arteries. Those are going to supply the head of the humerus. Now, the arcuate artery is a branch of the anterior circumflex humeral artery, and it will run in the bicipital groove to supply the humeral head. So the arcuate artery is one of the important branches from the anterior circumflex humeral artery to supply the humeral head. Now, the humeral head is also supplied from the tendon insertions into the two tuberosities and the periosteum beside the anterior and posterior circumflex humeral arteries. And the most important vascular supply to the humeral head comes from the posterior circumflex humeral artery, because a little while ago, the arcuate artery was thought to be the most important supplier for the humeral head, but now many studies confirmed that the posterior circumflex humeral artery is more important and is the most important to supply the humeral head. Now, in 3 and 4-part fractures, the anterior supply is compromised and the blood supply is mainly coming from the posterior side. And this will increase the risk for ischemia and avascular necrosis. Now we have a predictors for the ischemia, and they are called the humeral head ischemia predictors, which are the Hertel criteria, and those include that the humeral head ischemia is predicted if the calcar length is less than 8 millimeters. And the calcar length is the infерomedial cortical extension of the anatomical head to the surgical neck. So as you can see in this picture here, if the infерomedial cortical extension, which is this that you can see right here, if this is less than 8 millimeters, then this would predict the humeral ischemia. So if we, let's say, had a fracture here, and it would cut the cortical extension of the humeral head, so the calcar length is less than 8 millimeter, so this would predict the ischemia of the humeral head. And the ischemia of the humeral head is also predicted if there is disrupted medial hinge. And as you can see in this picture, this is here is the medial hinge, and the medial hinge get disrupted if there is a fracture here and there's displacement with a fracture. So the humeral shaft would be displaced away, and this would disrupt the medial hinge. If there is a fracture but no displacement, then the medial hinge is not disrupted. Now, the humeral ischemia is also predicted if there is multiple part fractures. The higher parts involved, the higher the ischemia, and ischemia is predicted if displacement is more than 1 centimeter and angulation is more than 45 degrees. And Hertel criteria predict the ischemia of the humeral head, but not the avascular necrosis. Finally, let's talk about the proximal humeral fractures in children. So in infants and children, the proximal humeral fractures involve the physis and classified according to Salter-Harris classification. So in infants, it is mostly a transverse fracture, which is a Salter-Harris type 1, and reduction doesn't need to be perfect, and those fractures have good prognosis. And in children, it is mostly a Salter-Harris type 2, meaning it's a transverse fracture that deviates to the metaphysis, and reduction doesn't have to be perfect either, and even if there is malunion, these fractures still have good prognosis due to the high potential for growth and remodeling for the proximal humerus in children. And pathological fractures are possible due to the proximal humerus being a common site of a bone cyst and tumors. And fracture through a simple bone cyst usually heals spontaneously if the arm was rested in a sling for 4 to 6 weeks. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like and comment your ideas and questions. And this video is a part of a bigger class. It's called the Shoulder and Arm Trauma Masterclass. You can check it out. It will appear on your monitor right now.